So Nancy Young is a senior scientist at the CHEO Research Institute and a professor at the U of Ottawa Faculty of Medicine. She is one of the co-creators of this measure and has been on this journey of collaboration since 2009. We also have the pleasure of having Shonagh McCrindle, who is a co-leader for engagement with the ACHWM team. She leads a group that shares the measure free of charge and supports communities in implementing it effectively. And then we also have Carolyn Melro, who is a postdoctoral fellow currently with the network and an incoming scientist at the CHEO Research Institute and assistant professor at U Ottawa. Her research broadly focuses on Indigenous children's wellness, primarily through co-creating services and supports with Indigenous children and communities. So welcome all.
So thanks very much for the opportunity to share what is really a very large body of work that's been created by very many people who are too many to name, but some of them will be speaking to you today. So I'm delighted to present along with Shonagh and Carolyn on the Aaniish Naa Gegii, the Children's Health and Wellbeing Measure, which wasn't always the Aaniish Naa Gegii. So if some people are confused and remember the Aboriginal Children's Health and Wellbeing Measure, that's how it began. And the A changed because the children and youth asked us or gifted it a name, and that then we adopted as the A. So I'm going to start off. I like to begin with Mary Jo Wabano's smudge bowl and pictures of Manitoulin Island because they ground me in where this work began and where the question initially came from. So I'm a non-Indigenous heritage, and I've had the honor and privilege of working with many Indigenous people on this journey. And the concept of the journey or the need for the journey arose from Mary Jo. And so having her smudge bowl with me is always a helpful piece for me in starting any presentation. So I'm going to flip very Western for a moment and give you a bit of an agenda, which is that I'm going to do a bit of an introduction to the outcome measure, which was developed for and with First Nations, Inuit, and Métis children and youth, with a very heavy First Nations focus in the original stages. I'm going to do a bit of a review of the science because I know we've got some academics on this call. And then Shonagh is going to share some examples of how it's been implemented in 2 different contexts and the lessons learned from those. And then Carolyn's going to guide us through a discussion of the relevance to the Access Open Mind partners and communities who might be present on this call. If there's something I'm missing, please feel free to interrupt me at any point. So I'm going to start by telling you a little bit about our team. We sort of had 2 different arms of our team, and one arm focuses on engagement and building relationships, understanding what's needed to support communities, and to share results from our research to improve wellness in the community. And the other arm of our work is research, which is to design studies to address community needs, to discover new methods, and to produce results with partners. Now, like any being, our 2 arms are very much attached and we're very much a whole team, but we each have different strengths. And so I will use this slide to cue you as to where we are at any point in time. So I'm going to start with our journey. And Blaine has gifted this slide to me. So Blaine Wolf is a member of our team who couldn't join us today. But he thinks it's important, and I agree, to talk about the why of the journey. So Mary Jo came to us, as did other Indigenous communities, to say, we need data. We don't have data. We have national data. We have provincial data. We don't have our data. And she was really eager to have data to inform program planning, to support their self-determination, to honor data sovereignty, and really wanted to change the narrative from illness to wellness, because all the statistics we have on Indigenous people really narrow in on the illness. And how we did it was in partnership, embracing Indigenous ways of knowing with measurement science, integrating tablet technology, which Mary Jo calls our happy accident, and generating data analytics that produce immediate results to support children, health staff, and leadership. And so we've really brought two different lenses together, but we're always trying to work on the balance of those two lenses and remember both of them. So our journey was one of co-creation and co-ownership. It was a joint initiative between Wikwemcom Health Center and academic researchers. I was at Laurentian University at the time, and now our team is at the CHEO Research Institute. We followed the OCAP principles and the IQ principles, which are Inuit principles that guide us in good ways of working together. Our guiding principle has always been put what is best for each child first. So if we ever couldn't figure out how to do something or what the right decision was, Mary Jo would always say, what's best for the child? And my IT team in particular has suffered from this because I will make them work very hard to make things much easier for the children. And they're like, but this is not so easy for us. And I was like, I'm sorry, the children win. So that's always been the piece that's guided us. So as we move from engagement, I'm going to tell you now about some of the research. So this came out of community and the need for data. What we designed was an inductive qualitative design. We did 4 community consultation meetings, we had 4 advisory meetings, and lots of conversations in between that led to 6 focus groups that engaged with 38 children who used photo voice techniques to give us an idea of what kind of data we should be generating. And these are pictures of one of the older youth boys group at the top and the girls group in the middle. And I think that was sort of our middle age group of girls. And what they produced was 206 concepts. That's a lot of concepts, that's a lot of questions. But they distilled it down to 58 questions, and that was done through a democracy exercise where they told us how important things were to them. And those 58 questions became 62 questions because there were 4 added later by other communities. And I am including the references for the work at the bottom of the slides. Don't feel like you've got to write it down because they're all available on our website. You can download them from the site. And if you can't, I can certainly share them with Gina and distribute them afterwards. But all of the papers were co-authored by not only the academic team, but also the community team. Often the academic team is first author, and that is by choice. The community had first choice on every single paper. It's not necessarily something they desired to do. So what we produced, we now call the Aaniish Naa Gegii, and there is the website, achwm.ca, if people want to capture it to get more information later, but don't do a deep dive into it now. What came out of this was a tablet-based measure that takes about 10 minutes for children or youth to report. And there's a picture of the tablet and one of the questions that were generated from the wisdom of children and youth. It's grounded in the medicine wheel teachings, and this picture is not a balanced wheel. It has many more emotional questions than it does mental or cognitive questions. And that's the balance that the children and youth decided it should have. That's what they put into it. We did not rebalance it. We followed their lessons and followed what they've asked for. It helps children 8 to 18 years of age start conversations about wellness that are strengths-based, and I'll get a little bit into that later. And it's supported by science because this was the original ask. They wanted something that could also be used for advocacy, to say to the government, hey, we need additional funds to support more mental health workers or to support a new physical activity program. They needed the science so that no one would poke holes in the data that they shared. And it generates automated reports, and that's become an important piece in keeping children safe. The important piece that we often forget is to remind people it's free. We're not charging communities to use it. We have funding from Health Canada and CIHR that allow us to gift this to communities. And it is a wellness measure. It is not a diagnostic tool. So the people who do diagnostic services are still critical in communities. This is not a replacement. So I'm going to tell you a little bit about the science. There is a decade of science that grounds this, and I'll go through this fairly quickly, but it is valid, it is sensitive and specific, and it is reliable. So the validity study, and anyone who's not interested in the nitty-gritty of the academic piece can just take a snooze for about 3 minutes. It was a cross-sectional study, and it was done in 2013. It involved 48 children and youth who did the ACHWM, and then they did the PEDS-QL, which is a paper-based, very Western measure, but it's used all around the world. We knew it might not be valid in this context, but it was the best we had. So we didn't expect a perfect correlation. When we got a correlation of 0.52, I don't think I can get my pointer to work. We were ecstatic about that. And the graph, sorry, I should go back. The graph that's here is showing you the correlation and the confidence we have in that correlation as ACHWM scores go up, PEDS-QL scores go up. The conclusion was that it's valid. We also were able to validate all of the subscales that are within the measure. We refer to them as quadrants. But they all had a parallel within the PEDS-QL, with the exception of spiritual. And that was one of the original reasons that we needed a new measure, because spirituality is not in the existing measures. But the children and youth put it in, and it could not be validated. There was nothing in the PEDS-QL to validate it against. We then looked at reliability in two different ways. We took two different cohorts of children and youth, and their data was analyzed using Chromebox Alpha. It came up with a Chromebox of 0.93, which says within the measure, the items do hang together. They do behave as a measure of wellness. And in the second cohort of youth, or children and youth, 29 of them did a special exercise for us, and they did it twice on that day rather than just doing it once. They did it once, they stayed with us, they played some games, they did some activity and some coloring pages, and then they did it again. And the reason we did it on the same day is we tried twice to do a test retest a week apart, and the kids changed too much. When we asked them if something in their life had changed, they kept telling us, oh yes, something has happened in the community, or something's happened in my family. So we did it on the same day. The main message is it is stable over time. Our interclass correlation coefficient was 0.94, which was spectacular. Speaks to the wisdom of the children and youth who created the content. So sensitivity and specificity is something that we're always looking to learn, to say, like, is it picking up kids who might have problems? And is it only picking up the children and youth who might have problems? And it was not bad at 75% and 79%. It wasn't perfect. So we went back and updated it in 2018 after we tweaked our algorithm. We took a new sample of children and youth and retested the sensitivity and specificity, and they were both above 80%, which means it's good at picking up children at potential risk, but it's not perfect. It's not diagnostic. It does tend to focus in well on children who might have risk, but it overcalls it. We will identify many children as having potential risk who a mental health worker will later say, no, they're fine. There's nothing here to worry about. We've decided we'd rather overcall than undercall. It's got a 97% negative predictive value, which means if the measure says there's no perceived risk, we're very confident there is no perceived risk. We will miss 3% of the time, and the 3% of the time that we miss are mild cases, so are not super concerning, but it's a little bit of work to figure out who's really at risk. So what do we know about the scores? So I'm going to focus your eyes on the chart in this one and not all the statistics that are on this page. This is showing you the distribution of the scores. So the line in the middle of each box is the median, the midpoint. Half of the children and youth are above it and half are below. But you can see that summary scores have a pretty broad distribution. And you can see that mental, which is on the far right in black, is the challenge in most populations. So this gives us an idea for communities of what they might expect in their data. I'm going to go through this one really quickly, but we've adapted it for use in other communities in a series of 3 different studies, and we have published those. We are relatively confident that with a few minor tweaks, we can fit it to the needs of most communities. Having said that, there are still a lot of communities out there that we haven't worked with extensively, and we're open to learning that there is more adaptation needed. So it was gifted a name by communities, and this is a picture of the group that decided to call it Aaniish Naa Gegii, and people will recognize Stan Wesley there, who is a motivational speaker and often was the facilitator for the COO conference until the pandemic. And Rita Corbiere is in the back with me. Rita has been the elder who's guided this, and Mary Jo Wabino is also there. And here's a picture of some of the names that have been gifted to it. So we started with Aaniish Naa Gegii, but every community has gifted it a name in their own language, including Ganawage, who call it Oniotanhachi. And I will apologize, Elder Tecumseh, for my pronunciation, which is far from perfect. So I'm going to go back to the engagement side. And let's talk about how we share it with communities. So this is how the thing works in the community. So a child or youth will complete it on a tablet. That information then produces a balance chart. And that balance chart is shown to the child or youth by a local worker. Often it's a health worker, sometimes it's an elder or other natural helpers in the community, who will talk to the child about their balance chart and celebrate their successes. But that local person also gets access to a brief assessment, which tells them if there's any potential risks that the child reported on the tablet. So this happens right as the child finishes it, and they can have a conversation. They can then upload their data, and if they upload their data to a shared server, it'll generate a community report. And that community report informs local decisions that guide programming within the community, and you can go back through the cycle and evaluate later if you choose. It's used at the individual level for strengths-based assessments, sometimes for triage and case management. It's used at the group level for program evaluation and research, and it's used by communities for population health assessment. We have no desire for a community to do one thing versus another. If it works for them, they decide how it works and what their purpose is. We try really hard to give data back in meaningful ways to youth through a balance chart, to local health workers through the brief assessment, and to decision makers through the aggregated report. And I'll show you what each of those looks like. But the layers of reporting is really important, that we make sure that it's not just used by decision makers, that the youth who gifted the data to begin with are served first. And so this is what a youth will see, and that's their balance chart. And we coach the local health worker to start with the biggest piece, to celebrate their strengths. The local health workers see a brief assessment. So they will see what's on the tablet here, which is teeny tiny, but it will show them any flags. Red flags are really worrisome, yellow flags a little worrisome. They can also record it on a paper document if they need to, because many communities are still on paper charts. And there's a flag system based on 18 questions, so it's not just one question. And it informs a discussion to verify what we call potential risk, because it's a tablet, who knows? We connect youth to a local health worker who can decide if they're really at risk and connect them to the local safety net. The local health workers are essential. They are the secret sauce that makes this work. And I'm going to skip past this because there's a lot of detail here, but they celebrate strengths first and have the skills necessary to support the children and youth, help them feel seen and heard, and keep them safe. community leaders have access to an aggregated report, which I mentioned before, and is based on pooled data. So we pull all the children and youth data together, and the kinds of things they have access to are a report that includes some graphics that are automated and they can access whenever they need to, a database that is theirs that they can download and store locally, and an analytic spreadsheet which will help them ask questions of their data and interpret it without the need for an analyst. So I'm going to take us now from theory into practice. I'm going to turn it over to Shonagh, and she can tell you about this example.
Got a couple examples of folks that we've worked with recently and further back. And I put a lot of information on this slide just to demonstrate some of the questions that come out of it and some of the results. So I got permission from Christian Island Elementary School to share their success with using the measure as part of how we promote it. And so in last year's report, the kids said 90% of them said they were proud to be part of their community, grateful for what they had and that they felt safe. And what a wonderful good news sort of feeling, right? Like that's pretty significant. 85% said that native language was really important and knowing about traditional medicine was really important. So those are ways that that school can then maybe plan programming, look at bringing in folks that can teach language, folks that can teach about medicine. The second part at the bottom speaks to their things to notice. So those places where maybe there is a gap. So only 35% said they had a good night's sleep. And that probably feeds into their overall mental score, which I didn't share here, but it is one of the lower ones. Oh, yeah, I just have one slide. But that was something that they are addressing in some of their programming. They also noticed that the next two, so 20% said that they took time to connect with Creator or God. And the next one being 55 said it was important to spend time with elders. So this one, the program lead for the school made sure to really highlight, as there's a lot of different types of faiths and spiritualities in that community, because while it is Beausoleil First Nation, Beausoleil First Nation is a grouping of many different traveling and nations that have been put together through colonial practices. And so there's quite a divide as to what is spirituality on the island. And some people are still very attached. So he thought he didn't know how to navigate it, but he put it towards the parents, because I was there for a parent family sort of community visit. And he said, I want your help. I need to know how to navigate this because these numbers should be better. We could probably improve. And they were going to plan to meet with the elder programs and the long-term care sort of related supports that they do for the elders in the community and try and marry them. Marry is not the right word, but bring them together with the school so that the children could learn from the elders, and then the elders could also benefit from the energy and the verve coming out of the youth. And then the last part sort of speaks to some of the anxiety that a lot of the students are exhibiting, and the 80 and the 85% are a hard number that he was able to use, put into a report, and then submit for bringing in a weekly psychotherapist. So now because they have these stats, they were able to argue isn't the right word, but advocate to bring in specialist supports. And I just thought, that's exactly what it's for, to a certain extent. That's one of the purposes of the measure, is to advocate for increased services. So that's one example of a school board that's using it, or school specifically. And the next one, as you see, is a little sparser. So Nogdaman Children and Family Services, again, got permission to share that they're using the measure. I wanted to speak to you a little bit how they use it. And I'd say they've been using it for 3 years, and they're probably, I want to say super user, because their leadership is really, really keen on doing evidence-based care. So at first, they just started using it as a pre-service tool. Check in with the youth that are coming into their program and get to know them and show them their own balance chart so that the child can also get to know themselves a little bit and just sort of start their triage and figure out what is their path in that program. Where do they need extra support and where they're doing really well. And then they are actually doing post surveys most of the time as well. So around 6 months in, they'll check in with them again. And that provides a snapshot of is what we're doing working? Is the intervention actually the right one? And it also provides them that program evaluation data. So they're able to provide information back to their funders to say, here, this is what our program is doing. This is an outcome, a specific outcome. It's not an output. It's not how many times they go to class. This is their overall health rating was at 57 when they came in, and now it's at 67. Like that's a big increase, and that's fantastic, and they can celebrate that. And then it also is a tool for identifying risk. And Nancy was just going over that, the flags. So if there is any imminent area of risk, there's a capacity to capture it and do some safety planning and engage the right experts to come in. So if there's suicidality or safety issues, they can really hopefully nip it in the bud and really start to help that young person feel supported on their pathway through whatever program that they're going through. And they also have culture camps that they use these with. So they'll do a screening. They'll do a measure at the beginning of their culture camp and at the end, again, just to check in and see was that camp an effective intervention. But it also, something that I've noticed when chatting with communities is they'll say, well, when they first came in, they don't know how to talk about how they're feeling. They don't necessarily have the language. They haven't necessarily thought about what it is that they're feeling. They just know what they're feeling. And then they go through the 62 questions, and it takes them 10 to 15 minutes, and it provides them an opportunity to self-reflect and on their own, in their own space. And maybe it takes them longer because they're really reflecting on it. But in that follow-up that the local health worker has immediately afterwards, they actually have a chance to, now they have words to how they're feeling. One of the questions is, I get so worried, I feel it in my body. That's anxiety. Maybe they don't know what anxiety is because they're 8, but they know what it feels like in their body when they're worried. And so now they've got some better understanding a little bit just through having read through all the questions. And just that alone is a gift in a sense of what this measure can provide. So yeah, and then I guess the little last piece was a summary page, but we'll skip over that. So that's me. Those are our 2 communities that have been happy to share why they really like to use the measure and why it works.
Thanks, Shonagh.
You're welcome.
I'm going to flip back to research very briefly, and then we're going to get to Carolyn. So the research piece is just mainly to tell you our current research. We're working on an older youth version that goes up to 29 years of age, mostly because we're funded through youth funding. If people decide they're going to use it beyond 29, I think it will have many of the concepts it needs. But if anybody is interested in that version, please let me know, because we are looking for sites to help us access youth who can inform the content of the new version. We know there's things that are missing. So our results so far have elevated the voices of Indigenous children and youth. We found a way to support their path to wellness with the support of the amazing local health workers, and we're empowering leaders to implement measurement-based care. Our current and collective challenge is to ensure that there's support for each young person based on the tablet's results. And that is the rate limiting step. How many kids can you support in a conversation? Because you might end up with half of the children who use the tablet identifying some risk. Some communities, it's only 25%, but it's never 0. And the ACHWM can be used by any or all IYS sites who have a focus on Indigenous youth. And Carolyn's going to guide you through a bit of that conversation. So over to Carolyn.
Thanks, Nancy and Shonagh. Yeah, so IYS, as we know, has been funded with an emphasis on creating measurement-based care, as well as creating a learning health system. And what we heard really by both Nancy and Shonagh is that the ACHWM is an Indigenous-led approach to developing a learning health system within organizations, so within IYS-Net's backbone teams as well as within the hubs. And it's really important point that Nancy said that this measure came out of communities wanting their own data. And so if we think about the IYS context, this is allowing hubs to have their own data that reflects many of the approaches in which this tool was developed. So making sure that it's youth and children friendly and culturally relevant to communities in diverse contexts, just as hubs are providing services and supports to reach youth within their diverse contexts. We've heard across the country the need for Indigenous evaluation methods. So this is a great example of how it could be used to support hubs and backbone teams to measure Indigenous youth wellness. One of the strengths as well of this measure in the IYS context is we know that there's some limitations to the data platforms that are being used in terms of flagging when someone is at risk or needs support. And so this is a nice way to assess if someone needs additional support and then ensuring that that young person is getting the care they needed within the hub. So these are just some high level how it aligns with the IYS initiative broadly, but practically, there's versions that exist for First Nation, Inuit, and Métis populations. It's both in English and French. There's also diverse measures for, or adaptations, for children who are in care and who may have unique circumstances and require additional supports at various points of their time in care. And it really allows for hubs to start a conversation with young people to celebrate the success. So what we also heard is that, youth don't want to do assessments because they don't see the value in why they're being assessed, that they're constantly being assessed not just for their mental health difficulties, but also within schools, testing, exams, and so they don't really see the benefit. But by creating that balance chart and putting the stories into their hands for them to reflect upon what they're doing well and to continue to build on what they're doing well is a real strength to this measure and is in alignment with what many folks have been talking about in terms of care delivery within IYS hubs. And it just really ensures that when we're providing cultural wellness services, so another conversation I've recently have been having is there's not enough data to show that cultural camps work. And so it's the first thing to be cut when there's funding cuts to programming. And so this is a tool that can be used to showcase that cultural, traditional teachings, land-based activities do influence Indigenous children and youth wellness, as we all anecdotally know, but policymakers, funders, they like to see that data. And so this is a tool that allows for that data to be shared in real time. So again, through a learning health system approach, taking the data through this tablet allows for folks to make decisions, and Shonagh showcased that in two great examples of how folks have been able to use the data to then inform service planning and delivery. And it can provide an opportunity to kickstart local conversations around the need for Indigenous measurement-based care. So we know that there's this top-down approach to what we need to report to show as outcomes of IYS, and it's very colonial, top-down, and this allows us to think about doing it in a new way. And I know that some hubs are working on creating an Indigenous evaluation framework to supplement their evaluation efforts of showing that the hubs are meeting diverse needs of youth. And so we really just wanted to to share this all, to have a conversation around what are folks thinking about in terms of measurement. How do you know Indigenous youth are doing well in the hubs or networks that you're a part of? So I would just open it up for